It's been 3 years since COVID first hit Massachusetts, forcing schools and businesses to close their doors and millions of residents to stay at home, pushing off everything from family gatherings to healthcare appointments. And since then, a lot has changed. The world's reopened, vaccines and treatments have made the virus a lot less deadly for many. And earlier this month, President Biden announced federal public health emergency declarations surrounding COVID will end in May. But when it comes to health care, as many as 2 million people in Massachusetts are still falling behind. According to the latest numbers from the state Center for Health Information and Analysis, more than 1/3 of residents say they've had trouble getting necessary health care. And as always, people of color in the state have been hit even harder. So what's making it so hard for people to access the care they need? Joining me to discuss this and the state of COVID here in Massachusetts is Dr. Katherine Gergen Barnett, the Vice Chair of Primary Care Innovation and Transformation at Boston Medical Center's Department of Family Medicine. She's also a clinical associate professor at BU School of Medicine, an associate at Harvard Center for Primary Care, and a Health Innovators Fellow at the Aspen Institute. Other than that, though, you're just sitting around doing nothing, right?
I'm so pleased to be joining you.
Great to see you.
Thank you.
All right, so let's start with the buildup of back appointments.
Yeah.
I mean, there's a statistical, mathematical funnel issue here, right?
Yeah.
Lots of folks couldn't get appointments. There's an urgency to some people who needed appointments. Where are we with the funnel ratio here for folks who are just trying to get back on the saddle of seeing their doctor?
So I think we have a perfect storm where coming into the pandemic, we already had a system that was stressed. So, the statistic that you give is really focusing on primary care and how are people getting in to see their primary care physicians. Coming into the pandemic, we knew that there was not enough funding for primary care. We can talk more about that. And we also knew that people were already stretched thin. Put on top of that 3 years of this massive overhaul of health, having us step in for everything that we could be, not to mention having the mental health crisis that we have, all kinds of needs of populations coming up. And now, as you indicated, a number of people just coming back to primary care and to health care. And so already you're thinking about why is the funnel so difficult? And then you think about what's on the other end of that funnel, which is a hospital system, which is incredibly backed up. So, for people who are sick, they can't really get into the hospital. And the people who are trying to get into nursing homes have a hard time getting into nursing homes or long-term care facilities. So there's lots of points of that vector where it's difficult.
Let's look at a couple of numbers here. For folks relying on emergency departments from 2015 to 2019, the breakdown of ethnicity and race, Black 20%, Hispanic 29%, which is a larger number than white folks who are leaning on emergency departments. And then if we look at the other part of the funnel conversation, primary care physicians who left the profession in 2020, according to the Center for Health and Information and Analysis in Massachusetts, 3.6%. Nationally, that's 3.3%. May not seem like a lot, but it is a lot when you come to just to Massachusetts. So we're seeing sort of the problems we had before the pandemic still there.
Absolutely, and getting worse.
Yep.
I think the emergency room piece and then people leaving primary care are two separate but related pieces, right? So the statistics about Black and brown folks going to the ED at higher rates, part of that is there's not a good access. We know we have a healthcare system that is inequitable, that doesn't provide the same kind of access. I work at a place called Boston Medical Center, so we're very thrilled that that's part of the work we do, but it's not sufficient. And then part of it, to what you're alluding to, is people leaving primary care. A lot of people talk about it as burnout, the sense of, a person just can't take it anymore. And as much as 1 in 5 physicians is supposed to be leaving or is indicated that they would leave the profession because of burnout. But frankly, I think myself and some colleagues really want to talk about it as a moral injury. So it's not the problem of the individual. It's not their fault that they can't hack it. It's fundamentally the system has failed them. It's failing all of us.
So what do we do? I mean, this is the challenge. As I've shared with folks, with my daughter's permission, she's got a number of chronic illnesses. We're in the system all the time. Her primary care physician, which was new, which she got just at the beginning of COVID, she's leaving. She's moving to a different to a specialty. She only saw her in person like once or twice, maybe, because of COVID. That's going to take a toll on treating your patients, that you don't get to interact with them in the way that you sort of signed up for. I'm seeing some reports folks are entering the medical care profession because of what they saw in COVID. And at the same time, dealing with the insurance companies, dealing with how long you can stay with patients, those things haven't changed either. Those are still hurdles.
Yeah.
So what do we do?
Yeah, do you have all day? Yeah. I mean, a lot of us are thinking about this all of the time.
Yeah.
So fundamentally, to come to the medical school piece, right? So you have seen that more people are going into medical school, which is terrific, or healthcare professions. The question is how many of them are choosing to go into primary care? So we know that medical students see primary care clinicians having this huge burden of responsibility on their shoulders. We are being asked to do more and more, target more and more metrics, some of which feel out of our control.
Well, also the mental health part of it.
100%.
I heard a pediatric primary care physician on a podcast talking about how when she was trained, it was here, you go see this person.
Yeah, and now we're that too.
Yep.
Which actually, a good primary care doctor can be that.
Right.
If we have the time and the capacity to build those relationships, we are trained, especially in family medicine and in other specialties, internal medicine, pediatrics, we are trained to do that work. We just aren't given the time. So if you're spending an average of 15 to 18 minutes per patient, and you're asked to address all their chronic diseases, plus mental health, plus housing insecurity, plus the concerns of everything else, that's not sufficient. So we're seeing medical students who don't want to go into it, and then I think we need to think about how do we restructure the actual care that's being delivered.
Last time we talked on the radio,
Yes.
we talked about someone I think called in was sort of shopping for a primary care doctor, but only
Right.
had a certain number of hospitals or practices that he was, I think it was for his parent he was shopping for. There's a pitch to be made here. You're at Boston Medical Center, which is a great facility. We are in a mecca, even though we obviously are having challenges. There's a lot of great doctors out there in a lot of places. So I know you don't want to shop around when you're sick or when you're looking for something, but we do have options.
Absolutely.
Don't just stick to the brand names.
We are so lucky in Massachusetts. We have great community health centers that are, where people live, where people worship, where they go to school, and those are great options. In fact, they really take care of the whole person, the whole family there. Brand names. BMC has a brand name too.
Yep.
I think it's really thinking about how do we pay people differently? How do we change the pay structure? So Medicare, Medicaid is on parity with private insurance, right? Because that's going to be the game changer in terms of some people's perspective of where do I go?
Primary care doctors.
Yeah, where do I go if I have this very elite healthcare coverage? Why would I go to the same place where Medicare and Medicaid is the majority of payers or health insurance?
Also, because some of the same doctors are there.
Right. Yeah. I mean, and all of us who work there could choose to be down the street. So, but that's not the point. The point is we all need to be working shoulder to shoulder. It's not about a competition. It's about the fact is that we all need to advocate for a groundswell and change. It's about payment structure, which Governor Baker had started in some of the work prior to him leaving office. Governor Keeley hopefully will pick up that work. Senator Friedman, we've been working really closely with her in terms of increasing primary care investment for Massachusetts, so really thinking towards the structural changes there. It also means getting lots more people into primary care. So it's not just about the clinician and the patient. It's about the community health worker. It's about the mental health folks. It's about the pharmacist. So making sure that all of those people are at the table and they're all getting paid.
All right, let's talk about COVID.
Sure.
And policy changes. So, this is this emergency change that the federal government is going to do. How's that really going to impact a regular person? What does that mean?
Yeah, so, again, we know that as these things roll out, every state's going to be slightly different. It's very much like what we saw as a pandemic was rolling in, every state reacted differently. We've been very lucky to be in Massachusetts. We know that Mass Health is going to cover people for a lot of things, but there's some places where we need to be aware. So federally, thinking about what's going to happen, we have a huge amount of antigen tests that are still stockpiled. Currently, we're going to still have those be free for people until those stockpiles run out. After that, we don't know what's going to happen. We don't know how much of a demand there's going to be for those tests. So I think that is going to be determined. I think in Massachusetts, with insurance, that will be covered. Same thing with vaccines. People with insurance here will be covered for vaccines. The big thing in terms of a hospital system, especially if you have older parents or you're older yourself, you used to have, during the pandemic, you were allowed to, if you're covered by Medicare, you could go right into a nursing home. Before the pandemic, you had to have a 3-day stay in the hospital before you went into a nursing home. It was like a do not pass go, collect $200, and then you can go, and then you can go. And it was actually a really good facilitated way of getting into nursing homes. The question is are we going to roll that back? Are we going to say, actually, you do need to stop again in the hospital? And what is that going to do for a hospital that's already crumbling under this, capacity issue? So I think that's something to be determined. And then finally, I think really thinking about telehealth, which has been an amazing leapfrog for us. I think you brought it up as a relationship issue. It's harder to establish relationships.
Right, but at the same time, it's also an amazing time saver, an access issue, and
an equity issue.
Yep.
So you can have 3 jobs and still keep your appointment with your doctor.
Right.
And so that making sure that we have parity on that moving forward, I think is going to be really important as well.
Where do you think we are COVID-wise? I mean, I'm not going to ask you to predict the future because none of us can, and we don't know what's going to happen. But it feels, as a user, that we've just kind of we've settled in, right?
Yeah.
I'm masking sometimes. I'm not always masking. I'm aware of people who are vulnerable. I'm going to follow the directions to get my next shot whenever it's time.
Thank you.
But so we're living with it.
Yeah. First of all, I think the regular citizen has become a public health expert in ways that we didn't anticipate, right? The good news is I think that makes us more aware when we have other viruses, what we should do to protect ourselves and protect others. I think you're right. I think we're sort of lilting in this new normal. The new normal is still pretty terrible, by the way. It's 500 deaths a day. So I think we can't forget that piece of it. I think there's increasing talk about this vaccine sort of being a yearly thing now, maybe when we know the virus will be most rampant when people go indoors in winter and things like that. I'm still sort of calling it peri-COVID, and that, we haven't exited, but we're sort of exiting, or to your point, I think we're exiting out onto a different platform than we were obviously in 2020.
And how are folks, the medical world, reacting to the long COVID? It's bringing a host of issues that people who have had chronic fatigue or, Lyme disease that has lived with them for a while or other viruses. And it's causing some forced progress on those fronts.
Yes, and I think we're still really trying to parse it out because I think, to your point, a lot of those symptoms could be attributed to other things. So we're still trying to distinguish what is sort of the nexus of long COVID versus these other things. How far do the tentacles go of long COVID? I think that probably will be better understood, a few years in the future. The fact is we need to be taking our patients' symptoms very seriously. We always have had to do that, but even more so now.
Well, we appreciate your expertise as always. Great to see you in person. Thanks so much.
So wonderful seeing you. Thank you.